talk about a number of things. I want to thank John Coleman, who's a colleague in Northwestern. He's a pulmonologist who works very closely with their ALS group. And he shared some slides with me and some opinions. And he's been influential in some of the way I think about some stuff here. Our agenda is pretty big. I want to talk broadly. If you've joined me before, for this gathering, just sort of talking about a model of thinking about symptoms, suffering, and healing, understanding what dyspnea is, dyspnea and suffering, its prevalence, some of the taxonomy, some of the language around it, dyspnea and anxiety, and then some treatments, oxygen, medications, and we're going to spend, I'm guessing, a good half hour at least. I'm going to sort of rush toward this because we really wanted to spend some time talking about ventilatory support, as well as discontinuing ventilatory support when it's appropriate, when it's right, and the process there. So starting at the top, this notion of patient, you've maybe understand the language of the word patient derives from Latin for patiens, for suffering. Patient is a person who suffers. That's all of us at some point. It's something that most of us don't choose to be, but become sort of victims, you might say, of circumstance that make us sufferers. And this notion of suffering, using Eric Cassell's language, some beautiful writing about this going back, gosh, now 30 years, it seems to me. The notion of suffering is a threat to our intactness, our integrity, our wholeness based upon illness, pain, worry, wondering, uncertain future. So the person who suffers is met by us, by those who care, with empathy. Empathy is a response to suffering, real or perceived. And that's what our job, in a sense, is to perceive others' suffering, to take folks who come to us with their symptomatic and disease challenges, and then to respond. And this is the action verb of compassion, is to respond to that suffering by turning toward and approaching our patients with healing. And I'm sorry I'm being a little poetic here, but this really matters as we're thinking about the process of interpreting the experience of dyspnea and treating it, and other symptoms. Healing, deriving from a word for wholeness, W-H-O-L-E, recovery of intactness, integrity, wholeness, that's sort of the counterpoint to suffering. That doesn't mean fixing, it doesn't mean curing necessarily. It means seeing one as they are and helping the patient feel whole again, find their personhood in a way, right? Patientness contracts us into those who suffer, and personhood helps expand us again to whole beings, seen as a whole human. That's the role of all of us, not just palliative care, but it's really sort of the ground on which palliative care was born. So with that in mind, I want to think about dyspnea. What is this thing? And dyspnea as suffering, compelling article from earlier this year in Neurology. This was a survey of just under 100 folks who'd suffered a stroke. And they were simply asked about 10 health conditions, how they perceive those on a scale that at the anchors were a fate worse than death or much better than death. What a remarkable way of languaging this thing. Not how bad is it, but how close to death is it? Relying on a breathing machine, these patients with stroke, 50+% of the folks who had a stroke considered this a fate worse than death. And another 12 or so percent, neither better nor worse than death. So around 2/3 of people just suffering a substantial symptom loss, capacity loss, functional loss, change in their future, looked at the possibility of being on a ventilator as a fate worse than death. That's pretty compelling evidence that this notion of losing one's breath or depending on a machine to breathe is unacceptable to many, and is a kind of suffering, certainly a threat to one's intactness, wherever they end up over time.
So I'm assuming this was people that weren't on a breathing machine or did not have a feeding tube.
That's correct, right. And so there's so many pieces of this that make it an imperfect study, but yes, these are people who I think, Peter, and I'm not honestly sure the timing now. I'd have to look back shortly after their diagnosis. This survey was done. Yeah, but early in the course, not yet on a breathing machine, right? And we know that things change over time too. So our initial impression of whether a breathing machine would be acceptable or not changes over time, and we're going to talk about that more. But at first outset, many in this audience might also think, you know, in fact, we could survey. I won't ask you to do that right now because it wouldn't be confidential, but you can think in your heart, you know, what do you think of the notion of needing to be on a breathing machine in order to keep living? And just listen to what happens inside your gut, your heart. So dyspnea, shortness of breath, its causes are many. It's a complicated neurophysiology. I won't talk with my neurology colleagues about all of that physiology, but three sort of primary causes: increased work of breathing, and that is the subjective, the perception of working harder to breathe. It happens when we run, it happens when we climb stairs, it happens when we get scared. If it's adaptive, if it's a response to an expected stimulus, it's not a scary event for most of us. But if it comes out of the blue or it comes with progression of disease, that increased work of breathing, shortness of breath, is aversive and not acceptable and is a kind of suffering. Hypercapnia, hypoxemia, this is when the body perceives that our carbon dioxide level is rising, our oxygen level is lower. There are various perception receptors in the aortic arch, in the brainstem, other places that receive these signals and that drive the body to breathe harder to compensate. There's a kind of dyspnea involved in that some people are aware of, some people are not. And then not entirely a separate dimension, this neuromechanical dissociation. This is when the striving to breathe is not being met by the actual breathing. It's a mismatch between our sense that we need to breathe and our actual breathing. And the way we can experience that is try breathing through a straw for a while and see what happens to you. And you'll find that you're breathing really hard and you're not moving enough air. That dissociation is felt by many folks with neuromuscular disease and is a kind of dyspnea. How common is it? A range of surveys looks at this: people with COPD, emphysema and such, when just walking and dressing, 41%, 82% climbing stairs, patients on hospice, a high proportion, people with dementia, stroke 37%, ALS more than 50%, muscular dystrophy, nearly all at some point depending. Parkinson's disease maybe 30%, because we love to highlight our own here. Chris Tiroli's work from 2020, he surveyed folks with Parkinson's disease and asked them overall symptom prevalence on a lot of things, and just notice these in blue overall symptom prevalence and in orange uncontrolled symptom prevalence. So about 1 out of 5 of the folks with Parkinson at all stages of the disease, by the way, reported uncontrolled shortness of breath. Parkinson's disease, right? Who knew? So taxonomy and measurement. So many description clusters for describing the experience of shortness of breath. The ones I put here in bold are the most common ones in the setting of neuromuscular disease. Chest tightness is unique to certain, typically, primary pulmonary diseases, but the sense of work of breathing and being short of breath, breathlessness, unable to catch air, that's often the descriptor or some variation on the theme in this setting of neurologic disease. How to measure this? We'll talk about some pulmonary function testing. Donna, thank you for offering yourself and your model. We're going to demonstrate a couple things, or you will shortly. The measures of shortness of breath, we know that self-report is the only reliable indicator for the subjective experience of shortness of breath. And there's a range of these: the Borg scale, visual analog scale, many others. And it is a reasonable thing to assess dyspnea both at rest and with activity. Activity will increase cardiac output and increase the shortness of breath in almost all situations. Outward signs, our capacity to assess a person's experience of dyspnea, are far from perfect. So looking at how fast they're breathing, what their oxygen level is, even what their pulmonary function test is, that may or may not correlate well with their felt experience. We'll talk more about that momentarily. The evolution of respiratory insufficiency in neuromuscular disease. So starting with subtle things, abnormal gas exchange during sleep, usually not felt by patients, and then sleep study disturbances if you were to get a sleep study. starting around a forced vital capacity, and this is a total amount of air one can, with will, with intention, move. Donna's going to have this demonstrated, or part of it momentarily. At a drop less than 40% of predicted, you might start seeing symptoms of sleep disturbance and some abnormal daytime gas exchange abnormalities if you were to check a blood gas. Daytime symptoms start arising when that forced vital capacity is under 20%, not always, but just as a rough measure. Then heart failure on the basis, cor pulmonale, of difficulty moving air, and ultimately respiratory failure. I want to talk about the dyspnea anxiety cycle. And I should stop here and there. Anybody want to share anything, please please say so, or unmute and yell out, okay? At any point. Peter, you were a role model in doing so. Really, I invite that at any point. So to say, there's some beautiful work done by a researcher in UK, Cambridge, talking about the dyspnea anxiety scale. She has devised a comprehensive dyspnea center for all kinds of dyspnea. So recognizing that the breathing, the sense of breathlessness, is infused largely by a difficulty moving air, or at least perceived difficulty moving air, as we described before. And that naturally, normally, adaptively, necessarily provokes anxiousness. It should do that. That's adaptive. That's necessary for survival. If you're short of breath because you're not able to move air, because you're underwater or not moving enough volume, you need to adapt to that in order to survive. That also triggers sympathetic overdrive, and in beings like us with the capacity to think about and wonder about what's causing this, thoughts about dying, worries about the future, anxiety, distress, and that anxiety piece of breathlessness increases sympathetic overdrive, makes the heart work harder, and increases the breathlessness. And she has all sorts of interventions, and we won't go into depth about this, but there are actually cognitive behavioral therapy interventions for the anxiety that is born of breathlessness. So it's an important thing to think about, not to ignore the importance of breathlessness in a patient with neurologic disease who can't move enough air, but to be aware of the fear of the breathlessness can be problematic. And one of the problems with the fear of breathlessness is the natural response to breathlessness is to avoid those things that cause it. So people who are short of breath tend to not do things that make them short of breath, like activity, like exercise, like engagement in life activity that matters to them, sometimes like lying down and sleeping because breathlessness is worse there. And you think about then the impact on their function of avoiding those things that make them short of breath. And those include deconditioning, less exercise tolerance, poor sleep, greater anxiety, and decreased functioning then builds on the breathlessness. So these are all positive feedback loops that are problematic in people with breathlessness. So a few treatments to consider. I shared this some months ago, this notion of oxygen. It is interesting when people talk about breathlessness, most often their families, and lots of clinicians think about a privation of oxygen. Give me oxygen, shortness of breath will be treated by that. And in fact, a survey of palliative care and pulmonary clinicians about the use of oxygen for breathlessness yields responses like this: palliative oxygen for symptom relief provides benefit regardless of their oxygen level. More than half of these experts in palliative care and pulmonology who were surveyed said, yes, oxygen can treat shortness of breath, whatever the oxygen level is. The vast majority of them prescribed oxygen for those who were feeling short of breath. And when asked why, because they had shortness of breath, because the patient requested it. And so this study by Abernethy et al. Actually looks at it's a randomized controlled trial of patients with normal oxygen levels who felt short of breath. And it can be randomized because they got nasal cannula oxygen or air. And there's no way to perceive the difference between those unless one is feeling better on one than the other. So they were both receiving air coming into their nose, one with a bit more than room air oxygen. Room air oxygen is 21%. 2 to 4 liters gives you, what is that? It's like 27 to 32-ish % oxygen. And in fact, you'll see then that the relief of breathlessness just with the air was measurable in both groups, but there was no distinction in the perception of relief, whether they received oxygen or room air. And so this and other studies like it have made clear that the symptom relief from oxygen is probably not any better than that from room air. And in addition, and like you asked this last time around, we were talking about this, and it won't be covered, by the way, oxygen, unless one qualifies with a low oxygen level in most cases, except on hospice potentially. So a response is no, oxygen is not needed if your room air oxygen is acceptable. But what might be useful, this dog may be experiencing the joy of having air splashed in his face, is air and blowing air across the face. This is an interesting study that looked at the improvement. This is a randomized trial of blowing air first in this person, first on the face and then on the leg for 5 minutes apiece. An improvement in shortness of breath would move this block down below 0. Shortness of breath improvement would be down here. So face, then leg, no improvement. Leg, then face, yes, improvement, meaning that blowing air on the leg didn't relieve their breathlessness. When they moved the air from the leg to the face, the group at large felt substantially better. And this speaks probably to some sensory receptors in the trigeminal, maybe in the nose. The fan is a great treatment for breathlessness in people who are short of breath with normal oxygen levels. Briefly, a little bit about medications for dyspnea. Opioids are thought of as the gold standard medication for shortness of breath that is otherwise being optimally managed for other underlying causes, pneumonia, asthma, whatever all else, primary underlying disease. In terms of treating the symptom, palliative symptom management for shortness of breath, opioids have been studied in multiple small trials, very little work done in the realm of neurologic shortness of breath. Short-acting opioids, and this is in SUM, S-U-M, a decent Cochrane review, looks at modest benefit, primarily in the setting of COPD for low-dose short-acting opioids, starting with very low doses. These are oral doses, 0.5 to 2 milligrams every 4 hours, for example. Extended release, probable modest benefit, again, modest doses. And again, the studies are not in neurologic disease. There's very little in that realm. Benzodiazepines, particularly we're talking about the dyspnea anxiety, breathlessness anxiety cycle. You might think that benzos are helpful, and we certainly know at end of life they can be. We'll talk a little bit about discontinuation of ventilatory support, in which case they are considered essential. No randomized trial there, I assure you. Cochrane reviews did look at cancer and COPD shortness of breath and found no evidence for or against. And this is based on small and not very good studies. There was more drowsiness. Antidepressants have been looked at, little evidence to suggest, and then no good studies in neurologic disease. There's a few small pilot retrospective studies. So that's the realm of opioids, probably helpful for some, benzos not necessarily, unless anxiety is really supervening. A little bit about excess secretions. So I put excess in quotes here because secretions may feel to be excessive, and they may be excessive to the capacity to manage them, but it's not necessarily because the body is making more secretions. Difficulty navigating, managing secretions that are being made normally becomes a problem in neurologic disease, Parkinson, neuromuscular disease, and such. So impaired swallowing of normal secretions and sometimes increased saliva production. We know that this does happen in the basis of autonomic dysfunction. So treatments are many: portable suction, candies and gums to remind people to swallow. I can never talk about swallowing spit without having to pause and swallow spit and think about losing the capacity to do that, as we do thousands of times a day. Anticholinergics can sometimes be helpful. They carry a bevy of side effects. Just to note, the quaternary amines, glycopyrrolate and hyoscyamine, don't cross blood-brain barrier, don't tend to cause sedation and delirium in those who are prone. Tertiary amines may, for many, so atropine and scopolamine may not be your first realm. Disease-modifying agents may help in both regards. And botulinum toxin injection in the salivary glands has been proven in multiple settings in neuromuscular disease, as well as salivary gland irradiation. That sounds rather extreme, but somebody who feels like they're drowning in secretions, for goodness sake, this might be a very dramatically enhancing for quality of life for folks who are suffering in that way. So I want to talk a bit about ventilatory support. Any thoughts, comments at this point anyone wants to share? There was a paper that several of us sent around to one another earlier this year in JAMA Neuro, talking about a call to action and need of support for patients. This is specifically with ALS, although it certainly is transferable to Duchenne's and other neuromuscular disease, about having the lack of, in most centers, a real systematic, organized way, structural, integrated into the system of evaluating and providing ventilatory support evaluation and treatment for patients with neuromuscular disease, despite real deep commitment to doing so. And this is no slight against any individual or any center. This is seen across the board, across the world, actually. And we're going to hear just a little bit about that from one of our patients. I want to share with you, I recorded yesterday some discussion with David. Getting a recording, I really wanted to have him here live. I will tell you, it took us 2 weeks to organize a sit down to do a little bit of recording with his blessing so that I could share this with you. And I would value, and you might as well, having him or others talk about their experience. But the 2-week challenge had to do with organizing this, getting him hooked up so that he could get on the Zoom, having caregivers around after he had all the hours of treatment every day in order to look me in the eye and talk with me about what was going on, have someone who could click the buttons on the Zoom. In fact, I won't show you the 5-minute preamble during which somebody in his home was trying to fuss with the machine as he grew ever more frustrated just to turn this thing on so we could talk with one another. So I share that all as a backdrop. David is 65 years old, and he is a father. He loves being a father to his now, I think, 8-year-old daughter, Leah, the light of his life, as he says. He's a partner to Lily. He's a CEO. He's a long-distance runner. And he had years of subtle, modest changes in strength and function before he was diagnosed in 2018 with ALS. He started BiPAP at nighttime in 2019. And I asked him just to share a little bit with us about non-invasive, NIV is non-invasive ventilation, and his thinking about it. So so bear with as I wasn't able to incorporate this here, so I'm gonna just flash through. And please give me a thumbs up or thumbs down if you can or can't hear. I think I have this set up so you'll be able to hear it. I'm gonna play for about 3.5 minutes now. I'm going to stop and I'm going to play a couple more segments along the way. Okay. So Benzie, I'm looking at you. You I can see right now. If you could just give me if we're coming. Well, things are, when did you come to the point of recognizing you were going to need ventilatory support?
Well, I think it was, oh, sorry to interrupt.
It's okay.
I think it was neurology that first suggested it.
Okay.
Yeah, when I looked at the science, it was pretty compelling. So there were studies showing fairly significant improved life expectancy as a function of hours on BiPAP. Unfortunately, however, I'm told because of insurance, the onboarding process that I do just through the sleep study, which was an absolute disaster, to put it kindly. And I think that probably turns a lot of people off who could otherwise benefit and might otherwise be really good candidates. So I would say to the audience, to your colleagues, that there may be a lot of, call it remedial work needed to overcome negative experiences if that onboarding process went through a sleep study, because they don't know anything about ALS. They're really, really ill-equipped. It's just they test for the wrong things. It's just a bad way to go in general. And the other thing I would say is that having the right DME involved up front is supremely important. Again, it really colors the experience. And if there's any little comfort level gotcha, for example, it's not the right mask, the machine is not set up correctly, the typical patient will immediately want to abandon the whole thing. But, however, whatever, I just kind of, gutted through it, did all my own homework on it, and found stuff that worked. But the thing that motivated me was the clinical data that showed improved outcomes. As I said, as a function of that, I was short of ID. The only other thing I think is worth keeping in mind for the provider community is the really critical role of caregivers. Early on, I could do a lot of stuff on my own. I never had a mask that fit right. But I used to sleep with the mask that I use at night. I used to sleep with my fingers jammed up into the nose pillow to position the mask correctly because it didn't fit correctly. I'm certainly not able to do that kind of thing anymore.
I'm going to pause for just a moment. For those who don't know, David is wearing, he's using BiPAP. We're going to talk more about. It just occurs to me. I wish I'd said this earlier. So this is the nasal pillows. This is compressed into his nostrils, and the machine is delivering a breath every time he essentially asks for one. And so what you're seeing as he's taking a pause, he's getting a breath in through his nose. You see he moves his head in order to accommodate that, and then allows air to come out to speak. So the ventilator is following his drive. It's not delivering a breath he doesn't want. It's delivering it when he needs it. And that's sort of the cadence you're seeing here. Just want to describe that. We've got another just about 45 seconds, and then we'll halt for a moment.
So the upshot of that is the emergency caregiver, because I've got to get this adjusted and that adjusted. Whereas if I demanded more of the DME, if I demanded more better performance in the equipment, it'd be a lot easier downstream. And I said the two with caregivers and a food. But in general, I think if the onboarding process is right, if there's appropriate attention paid to the machine setup and to all the equipment, all the ancillary goodies, well, it's pretty manageable. The benefit is pretty compelling. I mean, that's evidence-based.
So I should let you know, David is a man of strong opinion, as you're probably getting a sense. And what you won't see in this, because I just didn't have the space to discuss it at length, he was deeply grateful to his team of neurologists, the physicians, NPs, the pulmonologists, all those respiratory therapists. Several of you here. I know Cindy, he saw you, Donna, you went to see him in his home. And he has really strong opinions based on his experience. Things were really rough along the way. More coming momentarily. So non-invasive ventilation, it improves survival in ALS. So there's a lot of good data about this. This is looking a study from 1999, actually, some while ago, looking at patients who received non-invasive ventilation. Now, this is not randomized. This is a retrospective study of 3 groups of folks, and this is looking at their survival. So 50% survival. This is how we define median survival. Those who were wearing BiPAP more than 4 hours a day, 38 of them. I'm sorry, I'm going backwards. Those who refused BiPAP when it was offered, their median survival was 4.6 months. Those who accepted BiPAP but didn't wear it much, they lived a bit longer. And those who
I
accepted
think these people will come in for their Botox, but they won't come in for a follow-up.
Sarah, I'm not sure who's, I don't know if I can mute folks who are not muted, but if you would please, thanks. So there's good evidence about non-invasive ventilation prolonging life in ALS. This is following that same cohort and looking at the group who wore BiPAP and their decline in forced vital capacity, suggesting, again, this is retrospective, suggesting that early non-invasive ventilation actually slows decline in lung function too. So there's not only prolonged survival, there's slower decline, and not expressed well here yet is improved quality of life. There is one randomized controlled trial, a single center, back in 2006, looking at patients treated with non-invasive ventilator and 19 treated with standard care. They were divided accordingly, and there is for all those folks, the survival is about 45 days longer with a large quality of life improvement. Those with non-bulbar onset ALS had a very substantial increase in their median survival. Those with bulbar onset, so that being more head, neck, face control challenges, did not see that improvement, but did see some modest improvement in quality of life. Things have changed since then, and there have been improvements in diagnostic and technical and healthcare conditions for non-invasive ventilation in the subsequent 15 years. So it could be hypothesized that the survival benefit is larger. And just to share one study that took issue with that one, looking at those this is from 2016. Sorry, I don't have the credit down there. This is overall survival in a group who were, it's a large cohort study from Australia, overall survival improvement of 13 months. And those with bulbar onset also had a very substantial improvement in survival. Again, it's not randomized, it's not the perfect kind of study, but it's suggesting that in fact with improvements in non-invasive ventilation, that survival is increased in all folks with ALS. And there are some similar studies in other neuromuscular disease.
Rob, could I just make a comment?
Please, Cindy.
Okay, so I think I was probably the one who did the FEC testing on David when he was first starting to have changes. David, as you can tell, is not our typical person, but I just want to clarify when he talks about the onboarding process in the sleep study, most of our people don't need sleep studies because we can qualify them through the FEC. I just don't remember how his trajectory went, but he's one of our few that's followed regularly by pulmonology. So I think that made a difference in how he got to where he is today.
Right. I appreciate you saying that. And I really, you know, I want to come to everyone's defense, and Cindy, you being here particularly, because you've been incredible support to him. If in any way his edge, and he's got a lot of that, great gratitude, but also the edge that feels in any way personally directed. I know that's not the case. The sleep study, I'm not entirely clear why that was done. We're going to talk a little bit about what's necessary to qualify. And certainly a sleep study can be helpful in adjusting BiPAP for sleep use. I don't think that was his case.
Yeah, I don't remember. I just wanted to make the point that usually people don't have as much of a challenge as he described.
Right. Thank you for doing that.
Yeah. Can I make a point too, Rob?
Sure, please.
So I'm in pediatric pulmonary, and one of the things to think about is that if you think about how your lungs work, the chest wall expands your lungs, and their tendency is to decrease. So that if you have some time that somebody's able to expand their lungs, whether that's with BiPAP or with a cough assist or something else, to really expand your lungs, you're gonna counteract that tendency of the lungs to gradually decrease, and when they're when there's like little bits of atelectasis and there are smaller lung volumes, it's much more difficult to take a deep breath. So that physiologically, if you are periodically giving, like what we would account as a sigh breath, if you're periodically opening up the lungs, that's going to make it easier to breathe in general. So just a physiology point.
Great, thank you for that.
Rob, can I interrupt for just a second?
Sure, Deb.
You know, we've talked about several of the neuromuscular diseases, and I've always, just as an observation, I've always been very struck by with the longer course diseases like Duchenne, right, how well they compensate, and it's not very often that those folks will complain of shortness of breath until really pretty close to the very end. Even with, I mean, we have people with much less than a liter vital capacity that, you know, seemingly function in their minds just fine. Right.
Yeah, no, great points all. In fact, sort of to that point, Deb, no, and thanks, Karen, for speaking up. The symptoms, the exam symptoms may be subtle and may be deemed unimportant to patient, and they may not be feeling what we're perceiving. And it is not unusual for the care professionals to be perceiving a need for support when the patient's not particularly conscious of that for any number of reasons. I won't belabor this, but I want to move forward just to look, because we have Donna and Friend here, just to demonstrate what we're looking at. So respiratory evaluation, I'll share this. For neuromuscular disease, Medicare requirements are any of the following for BiPAP in the setting of neuromuscular disease. So any of a forced vital capacity less than 50% predicted, or a maximum inspiratory pressure less than 60, or a PaCO2, which would require a blood gas of greater than 45, or oximetry less than 88% for 5 minutes. Donna, I wonder, actually here, just before I do that, so people will know what we're looking at. Donna, you could describe this better. Karen, many of you could. But when we're talking about a forced vital capacity, we're going to be looking at maximum a forced vital capacity. That's the total amount of air you can take in and exhale. This is a picture from an article around those with muscular dystrophy who have less volume, can take in less air and put out less air. And this is compared with healthy controls, is where the percent comes from. Okay, those differences, those volumes. And we'll also talk about mean inspiratory, or maximum, inspiratory pressure for somebody, a healthy control, and then somebody with neuromuscular disease. Don, I wonder, can you show us what this looks like?
Yeah, so I've got Stephanie here. Do you want my microphone on and the whole coaching so they can see it, or do you want?
Sure. Let's hear you do your thing.
I am pretty genetically incapable of doing this quietly.
Yes, Donna is famous for being loud, so so adjust your speaker volumes at the other end to protect your eardrums. And you might want speaker view if you don't have that now, so you can enlarge Donna and our friend. Who's our friend?
This is Stephanie Castiglione. She's one of our ABA specialists at the Complex Care Center.
Thanks, Stephanie.
So I'm going to ask her to put on nose plugs, put the mouthpiece in her mouth, draw in a big breath as big as she can, blast it out as hard as she can, but keep pushing for a minimum of 6 seconds.
And you're measuring what now, Donna?
I'm measuring how deep a breath she can take and how quickly she can move it out. So
and this is called?
Forced vital capacity.
Thanks.
Okay, ready? So fight, lips tight, big breath, tall, bigger, go, 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 go. Keep pushing, keep pushing, keep pushing. You're almost there. Go, go, go. 2 more seconds. Suck in a deep breath. Good. Okay, you take it out and rest. So that's the predicted values are generally based on gender, age, and height. And you can see the shape of her loop here, and the numbers are here, and the percent predicted come up at the bottom. You have to do a minimum of 3 of those that are within either 3% of each other or 50 mLs, whichever is bigger, for the ATS standard. So you can imagine with neuromuscular disease, and also very often I need to hold the mouthpiece in, and all the, there's a lot of kind of modifications that we need to make. Do you want to see MVVs and MIPS and MEPS? All right, so.
Could you give us that? And I just have to say to the audience, I'm watching the few I can see and watching myself. Donna, you worked down the hall for me for 15 years, and I had some really big breaths when I was listening to you coaching our patients, I got to tell you.
I know. So, I don't let them slack. So the maximum voluntary ventilation is to see how much air you can move when you breathe as deep as you can, as fast as you can, for 10 seconds, and then the computer extrapolates it out. Dr. Voter could probably tell you better kind of what the percents are that they're looking for and things like that. But all right, so this one you're going to put the mouthpiece in your mouth, and you're gonna go, when I say go, you're gonna go as deep and as fast as you can for 10 seconds. So, okay, you can't stop. Ready? Go. Big and fast. Keep going faster. Come on, faster. You got it. That's it. Perfect. Keep going deeper, deeper. Don't lose it. Keep going deep and fast. Keep pushing. You're almost done. I can see the end. Keep going and stop. So that's maximum voluntary ventilation. And now you're dizzy? Are you dizzy? No. Okay. So that, and again, we have to have two of those that are pretty close to each other in order to say what's kind of real. So for respiratory muscle strength, with this, you can do this either on our Morgan machine, or Morgan Scientific is our manufacturer, or you can do it with a handheld manometer. And basically, I'm going to have her suck in a deep breath as deep as she can and hold it for a second, and then push out against resistance as hard as she can. Let me see if you can see the screen maybe a little better. And then I'll have her exhale all the way and then suck back in against resistance.
And Donna, this is to get the MIP, that other qualifier?
This is, yeah, inspiratory pressure is breathing in, expiratory pressure is breathing out. What does this say? Oh, this is, my computer is saying it's not going to do it.
Oh, okay.
So we'll do it, but essentially it's that big breath in, you create a resistance, and then they just push as hard as they can. I often have to hold their cheeks so they're not, you know, you want to measure what's coming from their chest wall and not their cheeks. And then the expiratory pressure, or you breathe out all the way, or yeah, out all the way, and then suck in for inspiratory pressure, deep breath in and blow against resistance for expiratory pressure. Okay. Peak cough flow is something that we measure annually until things start to go downhill, and then it's about every 6 months. So for this one, you're going to plug your nose, put that in your mouth, take a deep breath in as deep as you can, and just cough as hard as you can.
One cough?
One cough, one big, as hard as you can. Ready? Big, deeper, cough. Good. And that's peak cough flow. And we can also do that. You can actually do that really simply with a peak flow meter that you get like for asthma care, and you can put an anesthesia mask on it and have them cough into that with a nice seal, and we get their peak cough flow that way. Great.
Thank you so much for doing that, Donna, and Stephanie. Thank you for demonstrating. These can be done right there in the office. So the FVC, the MIC, each take a couple minutes at time.
A lot of it depends on recovery, because if you do it too fast with these patients, their efforts just get successfully worse.
Okay. Thanks so much for that. I should say Johanna Hamill wrote to all of us, and it's true, and I'm sorry we didn't make the point. Checking both upright and supine is important here. With diaphragmatic weakness, it may be supine is more sensitive to detect abnormalities here than upright, right?
Yeah, it would be hard to do that in a PFT lab unless the
right.
patient is mobile.
Got it. Thank you much. I'm going to go ahead, Donna.
No, I'm just, if anybody's got.
Okay. Thanks for that. Just because of time, I want to share just a little bit more. We're not going to be able to cover all the ground we wanted to, but I wanted to share this from David. There were a few things, and I'm going to skip ahead just so you can hear moments. I'm sorry for making this spotty, but I'm going to play this 3 little moments, and then we're going to share a little bit more of information.
The script was for a dirt ball bypass from, some manufacturer, and it was not a very good machine. And after a great deal of jostling and a huge amount of burn on some, really former work and underappreciated folks in pulmonology and neurology, finally I was able to get a trilogy. If I had been given the option to pay out of pocket 6 months earlier, $5,000, I would have done it in a heartbeat.
So he shares a little more here.
Because I looked at different machines, the oxygen was gone, and there was a curious device that I tried. The manufacturer's reps, the salespeople, put me in touch with the right people in the insurance company at Solace. So I ended up doing my own lobbying. That's how I got those machines to try. That should have been laid out right.
Okay, and then I just want to share one more little piece. He's talking about some of the crazy bureaucratic hurdles in getting the right stuff.
Less work. I mean, it just really pains me to see somebody who's just a brilliant clinician like Dr. Traylor having to fart around the insurance company. It's absolutely preposterous.
Okay, so absolutely preposterous. He says that they should have to. I want to share just a little bit so you'll know. He just mentioned a few machines you may or may not have heard. So BiPAP, biphasic positive airway pressure. This gentleman with ALS is wearing here with his partner next to him. This is giving continuous airway pressure, this expiratory positive pressure, and then when he takes an inspiration, more pressure, and then back down. CPAP is just maintaining this thing continuously. So this is BiPAP. He mentioned, I don't know, he said it was a dirt bag machine, the first one he got. He certainly has a wry sense of humor, and he's a bit of a cynic, but he is talking about a reality that in the insurance realm, insurance wants to be good stewards of their money and sometimes provide less expensive machines. I don't know which one it was, but you can get on Amazon and you can find I don't know if it's a dirt bag, I don't know what it's called, but you can find a BiPAP machine for as little as $1,000. You can pay as much as $5,000 as well. And there are multiple different interfaces, different kinds of masks, just to know about that, many of which he tried along the way and is eager to do more of. He mentioned as well, what he's wearing now is a Trilogy. There's a distinction here, and I'm not going to go into details. There are other people on the call who could, but it does much the same as BiPAP. It is more sophisticated, and it gives an average volume assured pressure support. So it's giving a desired volume, and it's more titratable and more sort of auto adjustable. It is a more expensive machine, and it's the one that has worked best for him. This is a brand. There's more than one, I think, that makes this average volume assured pressure support. Trilogy is sort of used as a generic, which it's not. He mentioned a cuirass. So this is what a cuirass is. It's a breastplate. It's like the old iron lungs, which one can wear, and it provides external negative pressure. He tried this at home. Trawick got this for him. Dave Trawick, I know Cindy and others were trying. David got this thing for him, and he just found it miserable, constricting, and it wasn't helping him out. This is an option. I don't know of any good data around it being better than another, although it certainly frees one's face from the BiPAP mask. He mentioned, or maybe he didn't in this segment, but cough assist. And you did, Karen. So the notion of clearing airway secretions, there's good evidence that doing so is really important because folks with progressive neuromuscular disease have less ability to do so. Airway secretions get in the way of good ventilation and respiration. This is one way of offering it. This is another kind of ventilator that or non-invasive ventilator called mouthpiece ventilation. In order to use this, and there's some interesting stuff in a site in Ottawa. Ottawa's got this CanVent collaborative, I guess is really what it is. This is a guy named Mr. Rabinowitz, and CanVent has really been advocating for the use of mouthpiece ventilation for people who have head control and clarity and capacity to use. Mr. Rabinowitz with ALS has enough head control, which David doesn't, to use this particular thing and get a breath when he needs it. He wears BiPAP at night. This sort of device offers some capacity to puff. There's sip and puff. Puff offers some control of various devices, including it can move wheelchairs about. And then this notion of airway clearance, which we just mentioned, the vest is another thing that David is striving for to help him clear some of the mucus. It's an external device. It doesn't blast air in and then suck air out. He did mention as well the Volkson. So David he has been a mover. He had this Volkson, which is really an acronym for the things it does. It's a ventilator, it offers oxygen concentration, and it does a cough assist built right in. He found that not to be tolerable either. And finally, this study from 2018 looking at the benefit. This is 470 some folks with ALS. One study, it's retrospective, but looking at daily non-invasive ventilation and airway clearance. And it appears, again, retrospectively an imperfect study, that those who started airway clearance and non-invasive ventilator earlier lived longer than those who did neither, for example. I'm just so conscious of time. I think